Good morning, everyone. We're going to get started. So welcome to Breakthrough Research webinar entitled Social and Behavior Change, Business Case, and Costing. I want to introduce myself. I'm Paul Hewitt. I'm the Technical Director of Breakthrough Research. And I'd like to take at least a brief moment to thank our USAID colleagues and AOR team, including Hope Hemstone, Angela Bransington, Avery Avarakatos, and Don Dickerson, among others, who have really helped to support this stream of activities and provided feedback throughout the process, and so we thank them. And I also want to point out that since we have a wide range of colleagues that are registered for this project, I'm going to do a very brief overview of Breakthrough Research and then hand off to my colleagues at Avenir Health for the substance of the presentation. So Breakthrough Research, as you may know, is USAID's flagship SBC project, specifically focused on generating research and evidence for SBC programmers and policymaking. It's a 5-year project from 2017 to 2022, and it's housed in the TRH program within the Global Health Bureau, but it also receives funding from other streams, including cross-bureau funding, PMI, and MNCH, among others. We work very closely with our sister project, Breakthrough Action, at Johns Hopkins CCP. They lead that, and they have a very large consortium as well. And I just want to note that there's a parallel stream of work on the influence or advocacy case for SBC led by Liv Van Lith, and I would suggest you follow along with the stream of results that are coming out of their activities as well if you're interested in this presentation. So Breakthrough Research works in multiple areas in the Global Health Bureau, and it prioritizes research evaluation in family planning, reproductive health, maternal, newborn, and child health, nutrition, HIV and AIDS, and infectious diseases. We currently have priority research themes within Breakthrough Research, including integrated social behavior change programming, provider behavior change, the investment case and evidence for cost effectiveness and cost benefit of SBC, which this presentation falls within, gender and social norms, as well as behavioral economics, innovative approaches to SBC programming. As you may know, the Council, as well as its consortium partner, conduct a range of research and evaluation from formative work to implementation science, effectiveness, and cost effectiveness analysis. So the consortium is made up of the Population Council, which is its lead. The Council has a strong and long reputation in doing research and evaluation across health areas and research utilization, including reproductive health and family planning, HIV and AIDS, poverty, gender, and youth. It has also had a long track record of leading large consortium donor projects historically in all 3 program areas. We work with the Institute of Reproductive Health that does a lot of research in global health, but also focuses on gender and social norms through example, the Passages Project. Our partner, PRB, is our research utilization and knowledge management partner. We have an academic partner in Tulane University. They focus on infectious disease research, malaria, and also effectiveness and cost effectiveness of SBC. We work with Ideas 42 in behavioral economics, evaluation approaches, and informing SBC programming with the behavioral economics lens, as well as our partners here at Avenir Health that are leading on the costing, the business case, and modeling of SBC work. So I want to do a brief introduction of their speakers today. We have Jim Rosen, who's a health economist and senior technical advisor for costing and financing at Avenir Health. He has over 30 years of experience working in costing and the application of costing principles to health programming. He's also breakthrough research lead in terms of implementing the business case for SBC. We have Willyanne DeCormier Plosky, who is a senior policy analyst at Avenir Health, who has 15 years of experience, including work at the World Bank and Avenir Health in policy analysis for programming and strategic decision-making. And finally, Michelle Weinberger, who's a senior associate at Avenir Health, a demographer whose focuses on modeling and analysis for policy and programming, including a track record of work in the Track 2020 program. So again, I'd like to welcome you to the presentation. I'm going to hand off to my colleague, Jim Rosen, to start the Avenir Health presentation.
Thank you, Paul, for that introduction, and thank you to everyone who's participating today in the webinar. Next slide, please. Our hope is that by the end of this hour, you will have a greater understanding of why it is important to invest in SBC cost analysis, something that is near and dear to our hearts. And then we're going to talk about some products that the Breakthrough Research Project is working on to improve and better use SBC cost analysis. These include an SBC Cost Repository that synthesizes what information already exists on SBC costs, Costing Guidelines that promote future costing efforts, and an SPC Business Case that uses cost data to make the case for investing in social behavior change. This webinar, we kind of see it as a logical follow-on to a consultation that the project held in March of last year, one that I think many of you participated in, where we first presented and got input on costing-related activities that we will discuss today. We're going to run through our presentations and then do a little Q&A at the end. The next slide. So we think costing can help the community of people and organizations funding and carrying out SBC interventions in a variety of ways. Knowing, for example, what it costs to reach a person with a specific health message can be very useful in setting a budget. You can work backwards from a target of how many people you want to reach, use that cost per person, calculate the total cost, and budget appropriately. Similarly, many SBC implementing organizations are offering their services to funders, including donors and governments, and knowing cost is critical to setting an appropriate price for those services. Now, while budgeting and price setting are often short-term yearly activities, SBC implementers also engage in medium long-term planning exercises such as the family planning costed implementation plans, sector-wide health strategies, and so on. And these planning exercises also can benefit from better knowledge of the cost of SBC interventions. When we want to decide whether a new way of doing SBC might be better than the same old way, then bringing the cost dimension into that decision-making process through techniques such as cost-effectiveness analysis can also be very useful. And of course, the cost element is key to comparing SBC to other interventions when we are advocating for greater investments in SBC. So costing of SBC has relevance in a variety of ways to the SBC community, yet we knew when we started looking closely at this early last year that the knowledge base on SBC costs was thin. So to talk about the SBC Cost Repository, one of our efforts to fill that knowledge gap, I'm going to hand it over now to my colleague, Willyanne.
Hello, and thank you for attending this webinar. My name is Willyanne DeCormier Plosky, and I will be presenting on the Breakthrough Research SBC Cost Repository. To begin, why is an SBC Cost Repository needed? First, there is a perception among policymakers that there is little or no SBC cost information to draw upon when doing advocacy or planning. Second, there is a lack of standardization that makes it difficult to compare SBC cost data across programs. Third, the level of detail in existing resources, particularly around intervention descriptions and disaggregated cost data, can be limited, which poses challenges for analysis. And finally, there is no centralized source available for SBC cost data at present. Next slide, please. So let's first turn to addressing issue number 1 on the previous slide, the perception that there is little to no SBC cost data available. As you can see, we conducted a comprehensive search of the peer and gray literature. Through the screening process, we found 130 studies, 35% of which were in family planning. Thus, we have been able to demonstrate that there is SBC cost data available. Next slide, please. Within the 130 studies, we have drawn out 711 cost estimates in the extraction. Note that there are more cost estimates than studies because there are often multiple cost estimates per study. For example, a study on mass media may have had one overall cost for the mass media program, but may have also had separate cost estimates for each type of mass media, such as radio, television, or live performances. Here we can see the distribution of the cost estimates, with the majority by intervention type in interpersonal communication and packages, the majority by region in Africa, and by target population among women and the general population. We can also see information on existing gaps in the coverage of the cost data, especially for data on SBC for service and program strengthening activities. There's gaps in regions outside of Africa, and for populations that may be harder to reach or who may have influence on decision making. Next slide, please. So moving on to addressing issue number 2, around the lack of standardization, we began by first seeking to define what SBC is and what specific types of SBC interventions, or what types of interventions could be classified as SBC. So we reviewed USAID documents, we conducted expert consultation, and we also referred to the Partnership for Maternal, Newborn, and Child Health's Social and Behavior Change Framework to decide upon the categorization that you see on your screen. The 4 main categories are interpersonal communication, mass digital and social media, packages, which includes community mobilization, and SBC service and program strengthening, which largely focuses on provider training. Next slide, please. Standardization of key fields was a critical process at the outset of extraction for 2 reasons. The first is that we needed to determine what key fields a variety of different users might use to search and sort the data on. The second reason is that users will want to be able to understand why 2 or more cost estimates may differ substantially. And I'll give you an example. So users using the repository may see multiple cost estimates for group IPC, but they'd want to understand why these cost estimates differ, so they would need more information and detail about the cost. For example, for group counseling, is it a doctor or a nurse or a volunteer that's providing the counseling? How long are the counseling sessions and how often are they provided? Are the counseling sessions provided through a service delivery platform such as a health facility, or are they conducted in a backyard? Each of these details can impact the cost, and thus it is very important to have standard methods for capturing and presenting this information. Otherwise, we have an expression in the United States, you want to be comparing apples to apples, not apples to oranges or broccoli or steak. Next slide, please. In addition to standardization of information about the intervention, there also needs to be standardization of the cost information. In the repository, the costs are principally broken down by cost type into total cost and unit cost. And unit cost is generally a cost per person served. So within SBC, we can see in the literature per person in the area, per person targeted in the area, per person exposed among those targeted, or per person participating in the intervention. The unit of measurement, or what we would call the denominator in a unit cost, is particularly crucial. This is because a unit measuring a cost per person in the area would usually be quite different from a unit measuring the cost per person exposed, the latter being a smaller sample size. So if you think about a division problem, the smaller the denominator, the larger the quotient or the result that you get. There are also other important cost designations that you see in the middle column there, such as the intervention phase. So is the cost capturing the design phase, for example, in with the implementation phase, or the startup phase that includes training in with the implementation phase? Also, is it an economic cost or a financial cost? An economic cost captures not only what the program paid for through financial costs, but also includes costs assigned, what we call opportunity costs, to volunteer labor and to donated goods, and in the case of mass media, donated airtime. Further, it is important to see what inputs comprise the cost. If a cost estimate omits, for example, personnel costs, you would really want to know that, because then you know that your cost estimate is incomplete. Because authors can put inputs like training or utilities, or especially SBC materials, into different kinds of cost categories, we needed to standardize the cost categories for extraction, and then where available in the studies, extract those input details and put them into our standardized categories. Then lastly, we needed to still standardize the data after it was all extracted by converting the data from the original currency that it was listed in. So if it was in rupees or in rand, we converted to US dollars. And then we also needed to convert to a standard year, which is 2017. Next slide, please. The standardization and detail in the repository has enabled us to start conducting analysis on the extracted cost data. Please note that what you see on the screen is preliminary. What we mainly want to show here is that the mean costs, which you see as the green circles on the slide, vary substantially between intervention categories. So you can see that the IPC and packages are about $6.50 and $7.90 respectively, while mass media is about 25 cents. So you may be thinking, oh, let's invest in all mass media because it looks so much less expensive. However, care needs to be taken in the interpretation of this data. While both IPC and packages have a denominator that is measured as per person participating, mass media is primarily measured as per person that is exposed or has recall of the intervention. Therefore, the scale in the denominator is very different. We also want to show that the cost varies substantially within the intervention category. So you can see on the left-hand chart the interquartile range, which is measured by the dark blue and lighter blue circles and is large for IPC and packages. On the right-hand chart, you can see that with the axis set to measure between $0 and $3 so that you can see the mass media distribution better, you can see that the mass media interventions also vary. Further, although unit costs of 12 cents for television per person and 26 cents for radio per person exposed may not seem to be an appreciable difference, we have to remember that these are interventions that are conducted very broadly. So they can be conducted across millions of people and over extended periods of time. So something which is one intervention is maybe double the cost of the other can sum to a very large difference in the total cost of the program. Also, I'd like to point out, you see there the live performances has a different, a higher unit cost. Partly that's because we have very few data points there, but also because there tends to be not as many people exposed to live performances as there are to television or radio, so it's not as broad as a distribution. Also, you see in the SMS or text messaging and phone call a higher cost. This is in part, I think, due to the denominator. The SMS programs or texting seem to be more participatory, so the denominator would be a participatory one rather than exposed. And in my thinking, this is really the difference we see in the costing between talking at people and talking with people. So really a difference in participation. Next slide, please. So to return to the original slide in this repository section, and point number 4 regarding the lack of accessibility, we wanted to show how the SBC Cost Repository and related products can make SBC cost data more accessible. The draft extraction workbook has a main extraction worksheet that can be filtered and sorted. There are also supplemental worksheets which help in clarifying the extraction process and which further specified our thinking about SBC intervention types and cost categorization. It was actually quite challenging to try and operationalize the SBC definitions when comparing against the intervention information that was in the studies. This workbook is expected to be turned into a more accessible and user-friendly web-based tool in the 3rd year of the project. And this web-based tool could be utilized to address the purposes that my colleague Jim Rosen presented in his initial slide regarding why costing is important to SBC. These include making data accessible for budgeting, price setting, medium and long-term planning, combining cost data with impact data to get cost effectiveness estimates, and of course for advocacy. And finally, the cost data from the SBC repository will be feeding into an SBC business case for family planning and country-specific modeling, which my colleague Michelle Weinberger will be presenting in later slides. So stay tuned for that. Next slide, please. Next slide, please. So the development of the cost repository has highlighted some key gaps for cost data that remain. There is a need for more recent data, particularly as interventions and technology change. And as seen in the cost estimates, there are gaps in coverage of SBC cost data by geography, target population, certain intervention types, and health areas. There is also no published guidance on standardized costing methodology that is specific to SBC. And it is important that reporting of SBC intervention descriptions, denominators, and costing methods be improved. Both of the latter 2 issues can be addressed by the publication of SBC Costing Guidelines, which Jim Rosen will speak about in the next few slides. He will also discuss the application of the costing guidelines to collect new data to fill some of these gaps. Thank you.
Thank you, Willyanne, for that summary of our work on the cost repository. Back over to me to talk a little bit about the SBC Costing Guidelines that Breakthrough is developing. Next slide, please. So you're probably asking yourselves the same question that we asked ourselves when we first started thinking about this product, which is, does the world, sorry, the previous slide. Oh, okay, next one. Go ahead. You can stay on that slide. Yeah. So you're probably asking yourselves the question we asked ourselves when we first started thinking about this product, which is, does the world need another set of costing guidelines? And we start with a observation I think it's hard to argue with, which is that it's really difficult to invest and plan without cost data of good quality that's standardized. And although there are many guidelines for costing of health programs that do exist, none focuses on the broad range and unique character of SBC interventions. And moreover, from our recent literature review and expert consultations that we've held, we know that there's a wide gap in measuring SBC cost. So these guidelines are meant to encourage more costing of SBC programming, fill the gaps in our knowledge, and help in the planning, budgeting, and advocacy. that we all know is needed. There we go, that's a slide, right? So the guidelines are organized around 17 principles grouped into 4 main categories of activities that every costing requires. One is study design, another is measurement of costs, another is how to price and value different program inputs, and finally, how to analyze and report on the results. Now, to avoid reinventing the wheel, we modeled the SBC Costing Guidelines very closely on the Global Health Reference Case for estimating the costs of global health services and interventions, which is a recent product of the Global Health Cost Consortium. So how can people use the guidelines? How can you use the guidelines? For the cost analyst, the guidelines provide SBC-specific guidance, which is embedded within each one of those 17 general costing principles, including some help for the non-SBC specialists on defining what exactly we mean by SBC. For the SBC implementer and programmer, the guidelines, we hope, are a way that can serve to facilitate conversation with outside cost analysts, help make informed decisions about costing, and help you understand whether the cost estimates from other settings might be relevant in your particular setting. And for the funder of SBC cost studies, our hope is that the guidelines prove useful as a way to set a scope of work for costing, to understand what constitutes good quality costing, what appropriate methods are, and what it costs to do an SBC costing. So to practice what we're preaching with our guidelines, we are piloting an application of the SBC Costing Guidelines for an upcoming cost-effectiveness analysis in Nigeria in collaboration with our Breakthrough Action colleagues. And the goal of that study is to compare a vertical malaria-focused SBC programming approach with an integrated SBC approach that combines messages across a range of health areas. Next, please. So that cost-effectiveness component employs a costing assessment that will measure the cost of designing and implementing SBC interventions and related service costs. We hope to answer questions about design and implementation costs, what changes occur in preventive behaviors, associated service costs from uptake of preventive behaviors. And the big question is whether an integrated approach is more cost-effective than a vertical approach in this setting. And our hypothesis at the beginning, next slide please, is that most likely the integrated approach will cost more than the vertical approach, so both the design and the implementation of the SBC interventions. But also the expectation is that the integrated approach will be more effective. So we'll have a preliminary answer to that question of whether integration is more cost-effective than a vertical approach at midpoint in the study about 18 months from now, and then a more final answer at endline in roughly 3 years. So at this point, I'm going to hand it over to my colleague, Michelle Weinberger, to talk about how we're using cost information to inform the development of a business case for SBC.
Great. So I'm going to talk about how the cost work that both Willyanne and Jim presented already this morning fits into a wider activity that's happening under Breakthrough Research, which is developing a business case for SBC. So first, what do we mean when we say a business case? So this is a term that really has its origins in the commercial world, but has been adapted into the global health world to talk about making an argument for investing in a particular health area or a particular type of intervention. and that generally within a business case, we can value returns in two different ways. So first, monetarily, talking about the cost savings in dollars, so health system savings costs, for example, by not having a negative health outcome happen. And then also in terms of health outcomes, so things like disability-adjusted life years or DALYs averted, which is a metric that lets us standardize across different health areas. So we can talk about the relative cost effectiveness of investments across a range of different health areas. So for breakthrough research, the SBC business case is going to produce a well-articulated evidence base that will support a range of USAID priority health areas. We're going to do this through a multi-pronged approach, which we'll hear a little bit about this morning, that looks at both the cost and effectiveness of SBC interventions. For this first year, we're focusing on family planning, but plan to extend the business case into other health areas, including looking at integrated approaches to SBC, so using the evidence that Jim just talked about that's being created in Nigeria as well as other health areas as well, so potentially looking at something like malaria. So we've heard a lot this morning about using costing data for a range of things, including both planning and advocacy, and we see the business case really filling a similar need. That is providing the evidence base to make a stronger case for why SBC investments are important in order to bolster those advocacy efforts, in order to help synthesize a wide range of evidence that exists on the cost effectiveness, and in order to guide decision-making on SBC approaches. The family planning business case will have two elements. So first, we'll have some case examples from the literature, so drawing from the SBC Cost Repository work that Willyanne spoke about. We did actually have a handful among those 130 studies that within the study themselves assess both cost and impact. So have cost effectiveness sort of fully from within a study. And so we're going to use those to provide some case studies of what that looks like. But also, because there is somewhat of a limit there, right? We have a large pool of cost literature that we can draw from, and we have a large pool of effectiveness literature, but the overlap between those is not too large. And so to better utilize both of those sets of literature, we're going to be doing some modeling in two countries. The countries that have been selected for this work are Guinea and Zambia. These were selected to align with Breakthrough Action's advocacy work, their influence strategy in these two countries, and also to provide a nice example of two different environments. So we have countries with very different levels of family planning use and very different situations in terms of demand for family planning. So to be able to demonstrate how SBC can play a different role in these very different contexts. So this diagram shows what the modeling component of the business case will do. So first, we'll look at scaling up a different set of SBC interventions in each country. The scenarios that are scaled up are going to be aligned with country plans and strategies, so looking into what they're specifying in their costed implementation plans and other strategies in the country for what they plan to do in terms of scaling up SBC investments. And from there, we're going to model two different things. So first, we're going to model the impact of that scale-up on increasing contraceptive use. We didn't talk about this piece in today's webinar, but hope we'll have another opportunity to present this work. But following a similar approach to what was done for the cost repository, we've also gone through a process of extracting data from the impact literature to look at the impact of SBC on both intermediate health outcomes as well as on increasing contraceptive use. Then we do a cost analysis, so to say how much will this scale-up of interventions cost. So this will draw directly from what Willyanne presented and taking those mean and median unit prices that came out of that work to say if we scaled up these sets of interventions, how much money would we need to do that? And then finally, by comparing the increase in contraceptive prevalence and the related health outcomes from that to the cost, we're able to get to measures of cost effectiveness as shown here. For example, looking at the cost per additional user, the cost per pregnancy averted, or the cost per DALY averted. So as you can see, the cost work feeds very directly into this business case and helping us to really make that statement about the cost effectiveness of SBC. So with that, I'm going to pass it back over to my colleague Jim to do a quick wrap-up, and then we'll have time for some discussion at the end.
Thanks, Michelle, for that great summary of our work on the business case. So just quickly to recap some of the reasons why it's important to invest in SBC costing. We know that costs are important for budgeting and planning to set a price for SB services for funders, and the synthesis of costs by intervention type and other key dimensions that Willyanne described, now part of our SBC Costing Repository, can be a key help in those efforts. And then, as my Nigeria example showed, the SBC Costing Guidelines can help to produce high-quality analysis that helps us answer key questions that the SBC field has about the merit of different and novel approaches, such as integration. And finally, as Michelle described, costing is really key to making a robust business case that will convince funders that SBC interventions are worthwhile for improving health and for overall social and economic development. Next slide, please. So this is a bit of the coming attractions. The Cost Repository, as Willyanne mentioned, available currently in an Excel format. We're planning to put that online in 2020, next year. The Costing Guidelines they'll be available a bit earlier in fall of 2019. And the midterm results from that Nigeria cost effectiveness evaluation will be available in early 2021. And the SBC Business Case, we're planning to launch with a focus on family planning later this year. So that ends our formal presentation, and we are now happy to entertain questions.
Great. Good. Thank you very much to our Avenir Health colleagues who presented this morning. Lots of interesting information about the SBC business case under breakthrough research. So for those online, we'd like to open up for questions or comments to you first. So please raise your hand as noted in the webinar instructions so we know who to call on. And then once we have a few questions online, then we'll go to the room. If there are any questions, one at a time. So please do note, keep your comments and questions concise, and make sure that your mic is unmuted, and we'll unmute you here on our side. So I'm going to go with Jessica Vander, who's online and has a question. Jessica, please go ahead.
Hi, Jessica Vandermark from Camber Collective. First of all, thank you so much for the great presentations, and I'm very, very excited about this work. I had two questions. The first one, quite simple. When you have the comparisons of, for example, cost per daily and the other outcomes that you'll have from the business case, will there be other comparison points to different types of interventions? And then the second question was, in a breakthrough action project, we've been consulting with different actors in the private sector, and they're very much interested in a business case for women's wellness programs, which will have a component of family planning. And I was just wondering to what extent this type of model could be relevant for putting into a private sector business case type setting.
Great. So I'm going to hand over to Jim or Michelle or Willyanne to address the question.
I'll take the first question. This is Jim, and thank you, Jessica, for the question. And yes, the plan is to compare the cost per daily averted that comes out of the family planning SBC business case, both to the standard WHO thresholds for cost effectiveness, as well as to other similar health interventions, both within family planning and within the broader range of health areas. So that's the idea with the comparison, the cost per daily averted comparison. And I think I'll let Michelle answer the question about the potential applicability of this modeling approach that you asked.
Yeah, I definitely see this having potential for private sector actors. I think, where the work that we're doing to look at cost and effectiveness is coming from a range of studies that include interventions that are both more within the public sector as well as in sort of NGO and commercial sector. And so it'd be great to discuss further how we might be able to make sure that our results are applicable to that wide range of audiences.
Great. So I'm going to read off a question that was asked by Jane Brown at Johns Hopkins CCP. How are you thinking about taking context and quality of implementation into account? Jim, I'm going to hand it off to you to direct.
I will pass that on to Willyanne, who's been leading the cost repository work to try to tackle that question.
Okay, so we did, in the extraction, we extracted on a bunch of different indicators. So in terms of context, we have it extracted by country, by the service delivery platform, and to address the previous comment, we also include a column for ownership, so it's divided out by public, private, or NGO. We also, in the cost analysis that you saw, the preliminary analysis, so far what we've done is to standardize the data in terms of we pulled out common denominators in terms of we really went back to the studies and made sure that we were comparing cost per person exposed for the mass media and for per person participating in the other types of interventions such as IPC and packages. We went carefully through the data as well to make sure that there were no significant outliers. For example, if they did not include certain costs such as personnel within their cost data. We also had as a minimum that the studies needed to explain where the cost estimates came from, that they needed to clearly state the sources. We're still working on determining further methods for if we're going to be doing more elimination in terms of quality. One thought that we have had is one column that we extract on is in the intervention phase that I described. In that column, some studies we have listed as not reported because we can't determine what phase the intervention is in. And that seems to be a particularly good indicator of the overall quality of the cost methodology in the study. So there are other potential avenues to address the quality on the cost side. We are working in tandem on the impact side for the quality of the study where we've extracted according to study design and other indicators. And we can discuss that more probably if that's requested in terms of impact, but I wanted to keep the focus on the cost.
Maybe just one thing to add to that is, in the extraction on both the cost side and the impact side, we've gone into both the published and the gray literature and have extracted across a range of different interventions, including ones that did not have statistically significant outcomes. And the point of that is to be able to look at sort of a full range of potential impacts and associated costs, recognizing that in the context of implementation, some things are done better than others. And so by not just drawing from sort of rigorous studies where we know that the quality of the implementation is likely higher because it's being done in this very controlled environment, by drawing from that whole range of programmatic literature, we're able to sort of understand the range of effectiveness that we might expect to happen under different conditions. And so we're hoping that that approach is helping us better reflect sort of the true potential of what impact might look like given different contexts of implementation.
Great. A question from Connie Gates. Comparing integrated versus vertical approaches, it seems that the comparison should be the several vertical that are combined in the integrated approach to avoid unnecessary duplication of effort. Is that clear to our Avenir Health colleagues? Or Connie, can you clarify the question a little bit, maybe coming online?
Yeah, this is Jim, and it's not completely clear. So if Connie, you can come online, I'd be happy to discuss that more.
Connie, I've unmuted you if you would like to speak to it. Clarify.
Yeah, okay. So we're going to, without further clarity, Connie, we're going to move on to the next question. If you want, just raise your hand. We'll get back to your question. So Emmanuel Kayonga asks, would the costing put into consideration what one is dealing with? For example, if one is addressing knowledge, it might require different approaches when one is dealing with norms. Therefore, would the analysis look at such?
Michelle, would you like to respond to that one and talk a little bit about how we're looking at the norms and so on, some of the intermediate indicators before you get to contraceptive prevalence?
Yeah, so we've been looking at classifying our outcomes based on sort of a range of different intermediaries for getting to contraceptive use, as Jim has just said. We actually made a decision not to focus too much on knowledge, recognizing that, we have a lot of evidence around changes in knowledge, but not a lot of evidence around the link of that to further behavioral changes. So instead have focused around attitudes and communication as more of our kind of primary intermediaries. And so what we're able to look at is sort of differences in both the cost of achieving changes in those intermediary outcomes, as well as then differences in sort of the connection between those intermediary outcomes ultimately to, at least in the case of the family planning business case, changes in contraceptive use. And so we think through the way that we've done this two-stage modeling, we'll be able to sort of mediate some of those issues. We're also looking to incorporate country-specific data to also contextualize where those things stand now, right? So in a country where norms seem to be a greater barrier, then those interventions are going to kind of be allowed to have more effectiveness, whereas in a country, for example, if partner communication is already very high in a country, then that channel is going to have less impact because there's less change to be had. So we're trying as best as we can to sort of take both country data as well as what we're getting from the literature to be able to mediate some of those differences.
Great. I'm going to open it up for any questions in the room. John Townsend at the Pop Council.
I love this presentation. All three were really good, and I really appreciate this is an area that isn't often well discussed, and you guys really have captured it. I wasn't sure how economic costs, if there was a standard way of dealing with economic costs in the literature that you reviewed. Oftentimes, SBC relates to community health workers, other people doing volunteer work, which is very different than a mass media thing where you can pretty much, the elements of the cost analysis are constrained. So was that dealt with consistently, and how would that change depending on how the intervention is designed? And the second question is, we understand that the local context is a big influencer of both the cost side and the likely effectiveness. But how is this linked to financing? Are there different cost strategies that make more sense to different financing strategies? Currently, we're thinking about lots of innovative financing, and maybe the criteria for what I can see for USAID is always, do you do this with cost per user versus pregnancy averted versus something else? But for other finance sources, are there other ways of presenting data that might be more attractive for a specific business case?
So Willyanne, why don't you respond to John on the question he had on the economic costs and what we found in the literature and how we're dealing with standardizing those, and I'll answer the question about that John asked about financing strategies.
Great. So thank you for the question. It's a very good question on the economic costs. First of all, we standardized how we extracted economic costs according to the principles in the Global Health Cost Consortium's reference case. What we did was we set up instructions for the extractors where first of all, if the author said that it was economic or financial in the paper, they looked for that. But beyond that, because within the papers, sometimes the authors aren't actually accurate in what they're quoting, sometimes it was an economic cost when the author said financial, we asked the extractors to be very careful to pay attention to keywords like donated or volunteer, so that they could extract the costs if they were costed, what volunteer time and, for example, donated airtime was. But beyond that, we had to be very careful because, particularly for social marketing, the way that they were using the term economic cost in the literature was very different. So in other health literature in family planning and HIV, economic costs are generally what I said, where they take whatever the program paid for, the inputs that they paid for, and then they add on the costs of like a market price for volunteer labor, for example, which can be quite expensive if you have, as you said, a lot of volunteers and you're assigning a market price to that. What they did for the social marketing papers is the authors would quote it as an economic cost, but really what they were doing is they were taking the financial cost and then subtracting the revenue. So it wasn't equating at all to the other kinds of studies. So what we did was standardize that in the extraction, where we said it's a financial cost, everything that is paid for, and economic cost includes anything that was assigned a price for volunteer or donated goods, and then we put the revenue in a separate column so that it's clear where the revenue was. So that's how we standardized across the different interventions.
Yeah, thanks, Willyanne. And John, to answer your question about the link between the business case and different financing strategies, I think really what you're doing is highlighting the fact that when one is doing advocacy, you have to keep in mind who different audiences or what might work with a different audience. So we're going to try to put together the family planning SBC business case in a way that meets the needs of a couple of different funding audiences. So for example, one audience might just care about, well, what's this going to cost me? What's the total cost going to be of scaling up SBC interventions in my country? So we should be able to calculate that for a particular country. The health folks, advocacy for them will be more effective using the cost per DALY or cost per QALY calculation where effectiveness is measured in health terms, to be able to compare SBC to other health interventions and say, hey, this is a pretty cost-effective thing to do. And then what we didn't mention in the slides or today is that also we're going to make the connection. We're going to also try to make a more of a return on investment calculation to be able to say you put $1 into SBC and you get $2 or $3 or $4 back. An argument that resonates more with the finance ministry, so they can be able to compare various returns on investments in SBC with what you might get from other health investments or development investments more generally. So I think that's what you're getting at. It's hard to always know in advance what's going to work with any particular audience, but we're going to try to make this business case as flexible as possible, recognizing that you've got different funders with different things in mind.
Yeah, I think you made some really good points, and it is the case that some people value economic costs differently. In the area of malaria, and there's a technology that's highly effective and doesn't require so many volunteer visits, but the procurers don't care about the cost of volunteer because the costs accrue to somebody else, and not the ministry. So depending on the business case and the funder, boy, you could be thinking very differently about how financing and what arguments would make sense. Good.
Great, and we're going to wrap up very shortly, but Jim, to get back to Connie Gates's quick question, she sent some clarification. I think what she's asking is, will the integrated cost assessment for integrated SBC include the cost efficiencies associated with integration, including time efficiencies, cost efficiencies, and effort efficiencies in your assessment? I hope that clarifies a bit.
I would say the answer to that, Connie, is yes, we're planning on doing that. I think also what you're getting at in your question is about what we're comparing in integrated versus vertical, and although ideally it would be great if the vertical included all the different health areas compared to, or looking at what it costs and what the impacts are in all the different health areas, summing that up and then comparing that again to cost and impact in the in an integrated program. We are in this particular case in Nigeria simply constrained by the way that the program is operating. So the comparison will be on the vertical side very focused on malaria, because that's the way that Breakthrough Action is operating in those vertical states, and then the comparison will be with another group of states where their SBC messaging cuts across a bunch of different health areas.
Thank you, Jim. For that response. And I just want to take this moment to thank all our Avenir Health colleagues that presented today, and thank you for joining the webinar. I would say look forward to some of the products and results coming out of the stream of work that were noted in the presentation. Please feel free to reach out to Jim Rosen at Avenir Health or myself, Paul Hewitt at Population Council, for any additional follow-up questions, comments, or requests for information. And again, please stay tuned to all breakthrough research webinars coming down the stream in the future related to the Global Health Program and USAID's objectives for social behavior change. So have a good day, and we'll see you next time.